Good morning. It is my honor and personal pleasure to introduce the first speaker of today, which is Professor Andisha Terbashi from Vienna. He's actually somebody who doesn't not need a big introduction, but I can say after 20 years of getting to know him that the two major accomplishments that he did is the current position of the chair of the Educational Steering Committee within the SIAP, where he organized many events, including this one, so he's responsible why we are so early here. But joke aside, on the position of the leader of NHL committee, he focused very much on rare lymphoma subtypes, which is actually the topic of this morning's session. Andisha, the floor is yours.
Thanks a lot, Jelena, for these nice words. Good morning, everybody. The topic of this education session is post-transplant lymphoproliferative disorders after transplant, and I see a few experts also here in the audience on this disease, which is fascinating me somehow because it's a very challenging situation. The diagnosis is often difficult, the treatment can be difficult, and we still lose patients from this disease. I think about PTLD, what is important, it's not much black or white, there's a lot of gray, because what we often forget is not all EBV positive diseases after transplant are PTLDs. You might suffer from EBV pneumonitis, you can have hepatitis or meningoencephalitis, and this has nothing to do with PTLD. Then what you all know is that not all PTLDs are EBV associated. PTLD, as you know, is a very heterogeneous spectrum of histopathological and clinical disorders. It is a rare disease, of course, and the diagnosis and treatment is, as I said before, often very, very challenging. This is a slide which I always like to show to the people. The question is, what is PTLD? Is it a pure infectious disease? Is it just a complication of immunosuppression, or is it a pre-malignant disorder? What do you think? Yes, of course, Adriana knows this. Yeah, it's all of above. When did the story of PTLD start? It started in the 60s when 3 living donor kidney transplant recipients were reported to have a post-transplant lymphoma, and these 3 cases were then published with 2 additional cases in 1969, and what was written in this paper was that it remains to be determined to what extent the appearance of neoplastic growth will be a complication of organ transplantation. At the moment, it appears that the incidence will be low enough that the usefulness of such procedures will not be vitiated. That it is not so rare after transplant, you will see later when I talk about the incidences, and that PTLD is the most common malignancy after hematopoietic stem cell transplantation, and organ transplantation is also something that we know very well now. So as an introduction, as I said, it's a spectrum of disorders in the setting of decreased T cell function. Most PTLDs are B cell disorders and EBV positive, especially those that occur after hematopoietic stem cell transplantation or early on after solid organ transplantation. The late onset diseases become more and more EBV negative, and here we see, of course, also the monomorphic disorders more often, so non-Hodgkin lymphomas. It is still a major cause of morbidity and mortality after transplant, and the problem that I see with this disease still is that there's a lack of really large prospective therapy trials. All what we do or recommend or is written in the papers is based on very small trials in pediatrics and case series. You know that the WHO classification system was updated recently, and we differentiate between 4 subtypes of PTLD. We have the non-destructive, the polymorphic, the monomorphic, and the classic Hodgkin-like PTLDs. The monomorphic PTLDs are the non-Hodgkin's lymphomas as shown here. The problem is also with regard to the relative distribution of these different entities of the WHO classification. The problem that we have, I think, in most countries, that there is no central registration of all subtypes of PTLDs existing. So we don't have any population-based data. Most PTLDs that we get aware of are, of course, those with monomorphic diseases, because they are the non-Hodgkin's lymphomas registered, whereas the non-destructive lesions, or what we said in the earlier times, early lesions, are not registered centrally, and this is also the case for the polymorphic PTLDs. And this is just an example. I took out one paper where they included more than 100 patients, and you see that early lesions were rarely registered or reported here in this paper. Then a few words about histopathology, what I think is also very important to know. When we talk about non-destructive PTLDs, as you know, this usually does not lead to a destruction of the lymph node architecture. This disease is usually polyclonal, and almost all of them are EBV positive. When it comes to polymorphic PTLDs, we already have a destruction of the normal lymph node architecture of the involved tissue. This disease can be monoclonal, but is also almost always EBV positive. And then we have the monomorphic PTLD, so the lymphomas. The Hodgkin-like, which is a very rare subtype of PTLD, is also almost always EBV positive. But in the non-Hodgkin lymphoma cases, we have 50% which are positive, 50 who are not. Still, the gold standard of PTLD diagnosis is histopathology. So you need a lymph node or a tissue biopsy in which the histopathologists perform all their analysis, immunohistochemistry, to establish the diagnosis. Here there are just a few examples. You see, for example, in figure A, a non-destructive PTLD, CD20 positive and EBV infected cells. In figure C, you see a diffuse large B-cell lymphoma, CD20 positive, but also with CD30 anaplastic cells. Then figure E, for example, shows you the typical Burkitt lymphoma. Figure F, a classic Hodgkin PTLD with the CD30, 15, and EBV positive tumor cells. These are just small data from Vienna. One of our colleagues, Elisabeth Salzer, collected or tried to get aware of all PTLDs diagnosed in Vienna after organ and hematopoietic stem cell transplantation. We could identify 21 patients, and you can see that 1/3 of our patients were non-destructive or polymorphic PTLDs, whereas 2/3 were monomorphic disorders and, as expected, diffuse large B-cell lymphomas. This slide is showing something we already talked about, the correlation between the category, the histopathology, and the clonality, but this should also show you when these PTLDs usually occur. Of course, the early PTLDs, the non-destructive lesions, usually occur very early, so within the first 3 months after transplant. Polymorphic PTLDs show a very variable onset of the disease, whereas the monomorphic disorders usually occur late or even very, very late. We are aware of lymphomas which occurred really years after transplant. PTLDs still contribute to the high burden of non-Hodgkin's lymphoma at all. So there are a few reviews which show that about 3% of all cases are PTLDs. We have this bimodal distribution of onset of disease, 1 to 2 years after transplant, 3 to 5 years after transplant. I already talked about the EBV correlation, so early onset diseases are usually EBV positive. The later ones could be more and more EBV negative. The PTLDs after hematopoietic stem cell transplantation usually occur very early. We don't have very late events, and the most important risk factor is, of course, the serological mismatch and the type of transplantation that we perform. The highest risk in solid organ transplant patients is due to the fact that the recipient is EBV naive and the donor positive, and this also explains, of course, that younger age is a risk factor because the younger children are usually not EBV infected. Then everyone is always asking what is the incidence and what role do the different immunosuppressive drugs play. It's not so easy to find very good, reliable data about this, but when you look at the review papers, you see that the lowest incidence is reported for the kidney transplants, whereas the highest risk is reported for the lung and intestinal transplants. With regard to the immunosuppressive drugs, the absolute risk is not really known or reported, but as we all know, or those who are involved in organ transplant or hematopoietic transplant patients, it seems that the calcineurin inhibitors have the highest risks. They have a higher risk than for the antimetabolites, than for the steroids and the mTOR inhibitors. Very importantly, as you all know, EBV monitoring and EBV is a predictive marker, but again, it's also not known from which cutoff the risk is let's say, very, very high. We usually react to the dynamics, and if there is a specific high-risk situation, but the absolute value is not known. And what I always find the most difficult thing is to detect a PTLD early on, because these patients often present with very unspecific, benign and variable symptoms, and it's very difficult to recognize this disease early on. This so-called fulminant disease, which is more commonly seen after hematopoietic stem cell transplantation, is very, very rare. These patients may develop HLH and they may even die in a very rapid way. I think some of you have seen such situations. And what we know is that early onset diseases of PTLD are more common presenting in extranodal sites and involving the graft, whereas the late onset diseases more resemble to what we know from malignant lymphomas, that they present in the nodal sites and sometimes with dissemination of the disease. So the most common sites of involvements are the lymphoid tissues, the gastrointestinal tract, whereas bone marrow and CNS involvement is very, very rare. Currently, we recommend to perform in monomorphic diseases the same staging procedures as for non-Hodgkin's lymphoma, so according to our revised International NHL staging system, whereas for non-destructive lesions or polymorphic disorders, it's not needed to perform a bone marrow or lumbar puncture because they usually don't have an involvement there, although I don't know whether this is really managed the same way in all your institutions. And of course, you need the EBV load to be assessed. And once more, a PTLD is not diagnosed by imaging or EBV in the blood. You need a tumor biopsy and you need the diagnosis by the histopathologist. Here, come back again to the patients that we had in Vienna, these 21 patients. You see that in 42% of our cases, there was a kidney transplant, followed then by liver and lung and hematopoietic stem cell and heart transplant. The most common sites involvement in our cohort fit very well to the literature, with the gastrointestinal tract being the most common site of involvement, followed by the cervical lymph nodes and followed by the pharyngeal and location. So do we have prognostic factors for the outcome of PTLD? There's also not very much literature available, but what we know from the case series, from the small trials, is that non-destructive PTLDs, patients at a younger age and single-site disease, have a superior outcome, whereas involvement of the CNS, bone marrow, late PTLDs, which are more often lymphomas, of course, non-B-cell disorders, CD20 negative B-cell disorders have an inferior outcome. But what do we call an event if we look at event-free survival rates of PTLDs? Of course, we have the classic type of events, which are non-response, progression, relapse, and death. But you have to always look very precisely into these papers, because there are authors which report something that we call a stringent event-free survival rate, in which the loss of the graft is also included as an event. What are the goals of the PTLD therapy? I think they are logic. We want to eliminate and control this B-cell proliferation, but we also want to prevent and control the rejection. We want to mitigate the increased susceptibility to toxicities, infections that these patients have. We want the immune system to recover against EBV, and this is only possible by a multidisciplinary approach. Such patients really need more than only the oncologist or the organ transplant or the hematopoietic stem cell transplant specialist. And what is currently recommended, as most of you know, is a multidisciplinary stepwise approach in these patients, weighing the necessity of treatment they need with the risks of the treatment and the preservation of the allograft. I think perhaps some would argue that that also the histological subtypes plays a role. I think the Burkitt PTLDs seem, according to the literature and the experience that we have, need more than just an immunotherapy with rituximab or reduction of immunosuppression, but I will come to this later, whereas all the other subtypes may perhaps be managed by this classic stepwise approach that we have, reduction of immunosuppression, rituximab, and escalation if there is a poor response. Then, of course, we talked about it, we have to consider the allograft function. Here we need, of course, the organ transplant specialist. We have to, and this is always for me very interesting, to discuss with the organ transplant specialists which degree of immunosuppression is needed, because suddenly we can go down with the immunosuppression. This is always interesting. Then it seems also, it's of course very important which type of treatment modalities you have available at your institution. Do you have the access to EBV-specific CTLs or not? And in these multimoribund patients, I think we should always also look at the overall health of these patients and then decide which approach we choose. Here you can see now the treatment options that we have. And I would like to go more into the details. Of course, you all know what RIS is, reduction of immunosuppression. This might work very well. It might very well work in preemptive therapy. We will talk about this. But what is very often not known, that this takes time. This is not something which solves the problem in a few days. It takes weeks that it works. And of course, you have the risk for an organ rejection if you reduce the immunosuppression. Then we have chemotherapy and rituximab. Rituximab we all know very well. It works very well in PTLDs. It has a very favorable toxicity profile. It can be used for preemptive therapy, and it is more and more used for a risk-response-based treatment. However, you cannot use it in CD20 negative diseases. Then chemotherapy, as we are all used to it from classic non-Hodgkin and Hodgkin lymphomas, also work, of course, in PTLDs with good response rates, good survival, but you may cause a lot of morbidity and even mortality to these multimoribund patients. Then we have the adoptive immunotherapy with EBV-specific CTLs. They have been shown to induce remission in relapsed and refractory PTLD. The toxicity profile is very well, but of course you can only use it in EBV positive diseases. It is costly, and you must have access to this specific cellular therapy. Then it is always discussed antiviral drugs and IV immunoglobulins. I think many people or many centers are doing it. The evidence for this is not existing. So we have no proof that antiviral drugs and IV immunoglobulins work in PTLDs. Now I would like to show you an interesting case just by imaging, a patient with a diffuse large B-cell lymphoma PTLD, as you can see here. In this case, the physicians decided, due to different reasons, to just perform reduction of immunosuppression. After 6 weeks, it worked. So this is always very interesting to see that just giving the immune system to recover, that it might lead to such a good response in a patient with PTLD. So it's still, reduction of immunosuppression still considered first-line therapy. It's almost always done. Complete remissions are more common seen in the non-destructive lesions and the polymorphic lesions. However, rejections can be problematic, especially when you think now of a patient who had a cardiac transplant. So yeah, it's always, of course, very important to discuss in an interdisciplinary manner how to deal with patients with PTLD. Then there's also a recent patient from my institution I would like to share with you, because this was a patient after liver transplantation and he was not doing well, so he was really critically ill. At the beginning we decided to just go for rituximab and corticosteroids. You can see the big tumor here on this imaging. You can see that the kidney was also involved. Here's the PET-CT. But the patient progressed. At the beginning he responded, the tumor got a little bit smaller, but then he progressed. So we then decided to go for a combination of, in this case, obinutuzumab plus CHOP. So rituximab alone did not work in this very classic Burkitt PTLD with a simic rearrangement and even a submicroscopical involvement of the bone marrow as shown by flow MDD. So we used obinutuzumab, which is also an anti-CD20 antibody, but has to the CD20 protein on the cell surface. So preventive and preemptive management. Prophylaxis would mean that you really look at the EBV status of the recipient and the donor and don't transplant if you have a high-risk situation. This is, of course, often not possible. Prophylaxis with antivirals and IGs is, as I said, this is very controversial discussed. In hematopoietic stem cell transplantation, we have these specific situations of the serological mismatch and haplotransplant, where I think it's called the Rome, conditioning regimen that we use, where we add 1 dose of rituximab to avoid a PTLD, and then we have the preemptive management, where, as I have said before, we have the option of reduction of immunosuppression, rituximab, and EBV CTLs. Preemptive, as you all know, means you see an increase of the EBV load, that you see some kind of dynamics, you know that there is a risk that this patient develops PTLD, and then you decide to already react. When we look at what kind of treatment options are currently existing for the treatment of malignant lymphoma in general, this is just the slide. We have, of course, nowadays more therapies in place that might be used. We not only have the chemotherapy, but immunotherapy. So we have the antibody-based therapies that you know very well. So we have, of course, rituximab, obinutuzumab, but there might be also options for bispecific or conjugated antibodies in the future. Then we have other cellular therapies like CAR T-cells, so beyond stem cell transplantations, and for example, Hodgkin's lymphoma, we have the checkpoint inhibitors. These options may also play a role in the future for the treatment of PTLDs, but we have already some data available about checkpoint inhibitors, and what all these trials showed that there was a very high rejection rate. So I don't think that this will be the future with checkpoint inhibitors in PTLD, whereas the other immunotherapy, cellular therapies could be an option in the future. This slide is very busy and not important at all in detail, but this shows you, this was done by Tom Gross and one of his colleagues. They, when we wrote a book chapter about PTLD, tried to summarize the most important pediatric and adult trials for PTLD in which chemotherapy and rituximab was used, and the two most, and here you can see the event-free survival rates, which were around 65, 70 to 75%. But the most important two trials from Tom, from the Children's Oncology Group, are shown here. In the first trial, including 36 patients, you see the numbers are very small in these trials. It was used a very low dose chemo, so cyclophosphamide plus prednisone, producing an event-free survival rate of 67%. In the successive trial, he already included 55 patients, and here he included, in addition to this low dose chemo and corticosteroids, rituximab. One very important trial came from the adults by Trappe et al. They did already a response-based approach in PTLD patients, in adults. So all patients received 4 doses of rituximab. Those who went into remission continued with a second cycle. Those who did not went then for, I think, 4 cycles of R-CHOP. And event-free survival rates or progression-free survival rates were 75% here. You can see the treatment scheme of the 2 trials published by Tom from the Children's Oncology Group. What was very interesting, and Tom always refers to this, were in this last trial that he had 12 patients who were by imaging positive at the end of the therapy, and 8 of them went into remission at a later time point without any systemic intervention in this disease. And explanation for this might be, of course, that the residual tumors were not active disease, but it might also, of course, be to the fact that the immune system started recovering, and it was a delayed EBV-specific T-cell response. What was also important from this trial from Tom was that they tried to find prognostic factors for the outcome of these 55 patients, but they could not identify any. So neither stage of disease, type of transplantation, histopathology, response at week 13 played a significant role. Then we have, as an option for preemptive therapy, but also for relapsed and refractory cases, of course, the EBV-specific CTLs, which can come from the donor, could be autologous ones, or of course third-party EBV CTLs. And as you can see here, you can only use it, of course, for EBV-positive disease, for refractory or relapse disease, as I said before, or if you think that the other type of therapy, for example, a chemotherapy, is not possible in your patient. I will not go through this slide in detail, because here you can see what Tom and his colleague did again for this book chapter. They also went through all the literature and small case series, case reports reported here. You see the numbers again, very small, but the response rates were quite good. And I don't know who of you has experience with EBV-specific CTLs. We did it in a very few patients, and it did not work in all, but it can, of course, lead to a complete remission in these patients. Now I'm coming, I think, already to my last slide, because I wanted to show you once more this response-based approach as reported by the adults, by this JCO paper from 2016. I already told you how they did it, but we had a very similar study in Germany, led by Hanover. It was the PET-PTLD 2005 trial, in which all the patients, even the Burkitt PTLDs, received 3 doses of rituximab, and then a response was assessed. Those who responded continued with 3 additional doses of rituximab, although I think it was not in a 1-week interval. The interval was I think, then for the last 3 doses longer, and those who did not respond went for a modified comp therapy, where M stands for methotrexate. And what was reported by the colleagues, and this fits also to our patient and to the literature, that almost all Burkitt lymphoma patients had to go for the chemotherapy arm because they did not go into remission after rituximab only. Patients who had a thoracic transplant, so lung or heart transplant, had an inferior outcome than the other patients, whereas EBV, stage of disease, early or late onset disease were not of prognostic significance. Yes, by this I would like to end with this short overview on PTLDs, which is for me still something very, very interesting and especially very, very challenging situation. I remember also 2 patients of us who died due to fulminant EBV disease. They developed HLH, and we had no chance to rescue them, and this was very, very tragic. And I know also from Willy and others that you have seen very similar patients. So knowing how to diagnose the disease, how to treat the disease, and being aware of the disease is, I think, something which is important for us as pediatric hemato-oncologists. Thank you for listening. I just forgot to thank also Tom Gross, who provided me a few slides. I think those who are working in the NHL world know Tom very well. He's also very much interested in PTLD and provided me some of the slides, and also was someone I consulted several times because some of our patients. Sorry.
Milan from Oulu, Finland. Thank you, Anish, for the presentation. I would like to ask, how would you treat T-cell PTLD, such as peripheral T-cell lymphoma type PTLD? We have a bad experience regarding one patient. So.
Yes, I think if it's a really monomorphic disease, it is something that most likely would be treated as a classic lymphoma. We will talk about these various subtypes of non-B-cell PTLD in one of our next sessions. But I think it's really important to know the exact diagnosis. What was this kind of lymphoma I think you're referring to? And then, of course, reduction of immunosuppression is always done. This is for sure. But if it's a malignant lymphoma, in most cases, I think we would tend to a chemotherapy. I don't know what you decided to do.
Yeah, this was a malignant lymphoma 5 years from liver transplantation.
Yeah.
Stage 4, we initially tried a reduction of immunotherapy, of course, and then R-CHOP type chemotherapy without any good response. And then we finally tried adult type brentuximab vedotin plus CHP without any good response.
Yeah. And we also had a similar case, but it was not T-cell, it was a CD20 negative lymphoma. We also tried to do it by immunosuppression reduction only. It did not work, and so we also then went for chemotherapy. I don't know really what you have experienced with T-cell PTLDs in a higher number. No. Yeah. They do badly, so it's I think we would go for chemotherapy. Yes, if it's CD30 positive, we would add, of course, perhaps brentuximab vedotin. Yeah.
So if CD30 positive, I think this is a very good idea. However, the experiences most of us have with these few patients are that they don't tolerate therapy, which they need, really. They need intensive chemotherapy.
What I would be interested, what would you do with a Burkitt PTLD? Would all of you go for chemotherapy, or would you try to reduce immunosuppression and do it with rituximab only and see what happens?
Well, coming from the German group, we have these experiences with these few patients, and I've seen myself 5 or 6, and none of them went away by rituximab. So we all went for MCOMP, and astonishingly, they don't need intensive chemotherapy.
Yes, that's the point, I think. You don't need the classic Burkitt lymphoma blocks. We did it also now with CHOP. No toxicity, and the patient, as I have shown you, went into remission.
Good morning. I'm Paola Mugio from Italy Bari. I would ask you if you have any suggestion about CD20 negative classical Hodgkin lymphoma PTLD, because I had 2 patients and they both were histologically revised, and the diagnosis is confirmed as a classical Hodgkin lymphoma. I mean about toxicity and chemotherapy reduction. We treated it with brentuximab vedotin and chemotherapy, but low dosage with AVD scheme without reduction on doxorubicin.
And it worked, and the patients?
They both did well.
It's very interesting that you're reporting, because I have never seen or involved in a Hodgkin PTLD. It's very, very rare. Although when you look at the literature, it seems not to be extremely rare, but does anyone else seen Hodgkin PTLDs? Yeah.
They both were following kidney transplantation.
Yeah.
I think the Hodgkin group, they summarized a few cases, and what the experiences are, the experiences are that they need classical Hodgkin therapy without that much of reduction, which is sometimes difficult, especially in liver and heart transplants.
Yeah. But the advantage with the Hodgkin therapy is that it's not very toxic, and it might be tolerated by these patients too.
If there is no other question regarding therapy, I have one regarding the diagnostics. Transplant people do a lot of analyses, and they manually monitor ABV status and what to do when you have, as we know, there is a dynamic, so increase, and in asymptomatic child, so should you go really hard on diagnostics, or should you repeat, like, do you need more than one increase in ABV copies to proceed with further diagnostics?
Now, we usually really recommend to repeat the EBV load weekly, but we also recommend to do conventional imaging diagnostics, because you could easily do a sonography of the neck, of the abdomen, of the mediastinum, and add a thoracic X-ray. If you're not sure, then you can even, we would even recommend to perform MRI, so imaging, to try to find the disease if there is already PTLD, because just the increase of EBV does not mean that there is PTLD, but we are very proactive to perform imaging in patients with an increasing EBV load. Exactly during the last week, we tried really with the organ transplant people at our university clinics to establish a procedure of diagnostics, because there are different people there, different organs transplanted, but we try to give a clear recommendation. But we are very proactive in imaging to find the disease. I don't know really what you...
I'm sorry that I talk again, but I'd like to cite Tom at this stage often. If you have an organ transplant, a solid organ transplant, not hematopoietic stem cell transplant, you can, the best way to say is that EBV viral load correlates to kidney function. So you can't say anything about rising or going down. It doesn't correlate with the risk of PTLD. So I know that the Hanover group is trying to find out whether EBV-specific T-cell monitoring might be the better option. EBV load is not really a good marker whether a child develops PTLD or not.
Karen, yeah.
One question, the follow-up of these patients, once you have treated their PTLD and they are still transplanted and they still need immune suppression, do you have any good ideas how to follow them?
As far as I know, perhaps I don't know it, is that there's no specific follow-up recommendations for PTLDs after organ or hematopoietic stem cell transplantation. I think it's very dependent on the institutions. We usually, I can just speak for my institution, we try to, we usually follow them up the same way as we would follow up a patient with malignant lymphoma without having been transplanted. And the organ transplant people, of course, do their own checkups, but these patients are followed up in our follow-up clinics of the Hem-Onc Center. So this is what we do.
And how do you handle immune suppression in the follow-up? Because our experience is that the organ transplanters want to increase it again.
Yeah, this is what this is always something we are discussing with them. We recommend, of course, to try to stay at the lowest possible level at the first time of the follow-up. But you're right. I think that they usually start increasing these immunosuppressive drugs again. But I don't know how it's managed in the different centers. It is very difficult to give here clear recommendations. But for example, in our last patient with this Burkitt, we really told them try to remain at the lowest possible level. And as I said during my talk, I'm really surprised what is possible if you really force the colleagues to lower the immunosuppressive drugs. So it's possible to be at a lower level.
So thank you, and thank you all. Having a good day.